Our final subject for this edition of ACCEL features a discussion Ray Gibbons had with Dr. Martin Thornhill, Director of Translational Research in Sheffield, England, and Dr. Mark Dayer, Consultant Cardiologist at Taunton and Somerset in England. They cover the incidence of infective endocarditis in England is increasing, an assessment of the impact of cessation of antibiotic prophylaxis using population statistics.
Welcome, both of you, to ACCEL.
Thank you.
I think it's important for our listeners that they get some sense of the enormous size of the project that you completed, because it was indeed based on population statistics in the UK. Mark, you want to kind of just give them the lay of the land?
Well, what we've done is we've surveyed the entire population of England over 30 years. That's 50 million people. And we've come up with the largest trial that's ever been done on an entire population like this.
So by any stretch, big data, certainly 30 years, 50 million people. And you began by looking at the response of that system to a recommendation from NICE. So I think our listeners need to know what NICE is and what the recommendation was.
Okay, well, NICE are the National Institute for Health and Care Excellence. They're an extremely influential organization within the UK, and they issue guidelines that are expected to be followed by practitioners in the UK. And in 2008, they published their guidance on antibiotic prophylaxis, and their guidance recommended that people shouldn't have antibiotic prophylaxis anymore. They made a very rational and logical decision based upon the fact there was no evidence of the efficacy of antibiotic prophylaxis.
So stop it completely.
Pretty much, yes.
And for the most part, did people do that?
People certainly did. And what we saw after the introduction of the guideline was a precipitous fall in prescribing of antibiotic prophylaxis, such that in 2013, in the last 6 months of our survey, antibiotic prescribing had fallen almost 90%.
So a dramatic response to this guidance, reflecting the impact of NICE in your system, and to some degree the integration also of dentists in your system, more so than in the U.S. Is that right, Mark?
Yes, I think that's true. Still, the substantial part of dentistry in the UK is carried out under the National Health Service. And so dentists generally follow guidelines issued by NICE, just as our medical colleagues and so on do as well.
So that's another difference from the U.S., that integration, and certainly the presence of this kind of countrywide data is very different from the U.S. So you then set out to figure out whether there was an adverse effect from this change.
We certainly set out to figure out what was happening to infective endocarditis incidence. We can't conclude any cause-effect relationship from an observational study, but the NHS does collect quite good data which allows us to work out what's happened, because everyone who's discharged from an English hospital, it's recorded what their diagnosis was and other comorbid conditions and problems they may have had.
So compared to the U.S., we would only conceivably have data on Medicare patients over the age of 65 on a national basis. So you have data on everybody coming out of the hospital virtually on a national basis.
We do.
What did you find when you looked at that discharge data nationally?
The discharge data nationally showed over time, before the introduction of the NICE guidelines, that there was a gradual increase in the incidence of infective endocarditis going on. We were able to project the trend line for that on past the introduction of the NICE guidelines. And when we looked then at the actual data for the incidence of endocarditis after the NICE guidance, there was an increase in the trend line. The trend line slope went up significantly. And as a consequence, by March 2013, so that's 5 years after the guidance change, we were seeing an extra 35 cases per month of endocarditis over what you would have predicted from the original trend line.
So were the trend lines that were in your talk, are they in the Lancet paper?
Yes, they are.
So for the listeners who are interested in seeing what those slopes actually look like, I would refer them to Lancet, which has just published the findings of the study we're talking about. Okay. And so let's get back to that number. How many cases?
Well, the data shows an extra 35 cases per month of endocarditis. It's a roughly 25% increase in the number of cases over what we would have expected.
And obviously the difficulty is knowing whether that is related or not to the NICE guidance.
We have no evidence to say that that is related to the NICE guidance. And there are potential other confounders that could have caused that. So the population is getting older, there's more diabetes, there's more valve disease around. So we will have to spend time looking for other reasons as to why this change may have occurred.
And as I recall from the presentation, these were patients where that was the principal diagnosis associated with the hospitalization. Is that correct?
Yes, that's absolutely correct. So it's the primary diagnosis on which they were discharged from hospital. We also made an effort to make sure that we weren't double counting cases. It's not uncommon for people with infective endocarditis who are diagnosed in one hospital to be transferred to another hospital for more specialist care. And using the data, we were able to track for those transfers and ensure that they were only counted once rather than twice.
So given the difficulty of saying whether this is in any way causative, has there been any comment from NICE about your study?
NICE have issued a press release today to say they're going to look at our study and evaluate it and see if they are going to recommend any change to the guidelines. They've emphasized that at present there shouldn't be any change in practice, and we would entirely support that view.
And I might point out for our listeners that the U.S. guidelines, typically over the years issued by the American Heart Association, also changed a while back to only favor prophylaxis in high-risk patients. So we still recommend it compared to what NICE said in 2008, but also acknowledge the absence of any randomized controlled trial data. Obviously, as was discussed at the meeting, very difficult trial to do.
Yes, I might comment before we talk about the trial about the fact that, being aware of the fact that guideline committees in the American Heart Association Guideline Committee and other guideline committees around the world had only recommended that antibiotic prophylaxis stop for moderate risk patients. It should continue with high risk patients. We did look at our population to try and see whether there was an effect in only high-risk patients or in people who were not at high risk. We did actually find that the incidence of endocarditis increased in both of those groups. So there is a potential message here that's broader than just for the UK. But as we've said, we can't say with any certainty at all that there is a cause and effect relationship. But as you say, I think it's important to kind of highlight the only way we can get better quality evidence about the potential benefits of antibiotic prophylaxis is through a clinical trial.
Which would have to be very large.
We're looking at more than 100,000 patients followed up for 5 years, which would be an enormous challenge to do.
Well, I think we can certainly understand that, and we'll look forward to whatever ideas anybody has around the world in terms of organizing that kind of study, because it would seem likely that it's going to take a great deal of collaboration in order to carry it out.
Yes, we have attempted to set up that sort of a study, and certainly the national health system in the UK, with the data collection that it does, makes it a possibility. And we did make a big effort to try and set up such a study in the UK. One of the other benefits at the time about doing a study there was that the standard of practice since the change in the guidance was not to give antibiotic prophylaxis. So that meant that medico-legally and ethically it would be simpler to do a study in the UK because you could randomize a patient to having antibiotics versus not having antibiotics, something which is more difficult to do in North America because you would be removing the standard of care in the control group of patients.
Right. fascinating discussion, and in terms of take-home messages for our listeners, a very large, very comprehensive study over many years involving the entire United Kingdom, a country of 50 million people, examining the impact of a change in guidance with respect to endocarditis prophylaxis in 2008 that said don't do it, and by and large, over time, it wasn't done. And in the same time interval, an apparent increase in endocarditis cases with a change in the gradual increase in those cases over time, accelerating. Unclear whether it's causative or not, and time will tell whether we are able to actually develop additional evidence about this interesting issue. So thank you both for coming to ACCEL.
Thank you very much.
Thank you very much.
That concludes this edition of ACCEL for May 2015. For details about studies discussed on ACCEL, refer to the written summary included as a PDF file on this disc. This issue of ACCEL qualifies for up to 4 Category 1 CME credits. To obtain CME credit, go to www.audiodigest.org/online testing. This is Alfred Beauvais for the American College of Cardiology. Thanks for listening.